My name is Michael Battal, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. The AASLD Liver Conference 2022 in Washington, D.C. was fantastic this year with so many friends and colleagues meeting in person. I know many liver specialists who savored every moment of this year's conference, and our special guest today is definitely one of them. Dr. Giada Sebastiani is a hepatologist and a clinician scientist. She's also an investigator at the Research Institute of the McGill University Health Center and a founding member of the Canadian NASH Network, also known as CAN-NASH, and a ton of other noteworthy appointments that we won't talk about today. Giada, what were your takeaways that you can share with us today?
Yes, Mike, thank you very much for inviting me first. It's always a pleasure to being with you and with the Fatty Liver Alliance. I think it's great that you are doing so much awareness about this deadly disease as you are doing. So the meeting was fantastic, as you said. I think there were many relevant clinical points that have been raised. For me, there were three main areas in terms of general topics that I truly enjoyed in terms of the presentations that have been sent by researchers. One includes lifestyle modifications. I think that it's important just to be reminded that lifestyle modification is still a cornerstone for the treatment of NAFLD and NASH. And there have been especially three studies that I liked very much in this branch. One was the use of NUM, so of an app for weight loss in patients with NAFLD. It was actually a randomized trial, so it was very interesting. It looks like the apps also work for patients with NAFLD in terms of the weight loss. The other was also a telehealth intervention for weight loss again. So we are switching more and more towards the use of telehealth and of apps also for the weight loss in patients with NAFLD. And finally, vigorous physical exercise was really very effective in inducing weight loss and also in changing the trajectory of the disease in patients with NAFLD. I also liked very much a presentation on social determinants, which I think is very important of health. I think it's very important that we take into considerations in the future in research also the social determinants of health, which can actually impact on the clinical outcomes of patients with NAFLD and NASH. And also I liked very much, of course, some presentations on the non-invasive tests, which are always very important for patients because we don't want to use liver biopsy always of course, to 25% of the general population who is affected by NAFLD. So there were some interesting findings, for example, on FIB4, which is one of biomarkers that we use a lot as a screening tool in patients with NAFLD. So first of all, that even if the FIB4 is low, still there was a study from the University of California, San Diego, there could still be some advanced fibrosis diagnosis with other non-invasive tools, which are more accurate. Also, the fact that probably FIB4 can be a little bit more inaccurate in younger patients, so maybe there may be a need for a different cutoff in patients who are young. Also, there have been several interesting studies on the use of non-invasive tools to screen patients with type 2 diabetes for advanced liver disease, meaning cirrhosis and hepatocellular carcinoma. Again, this was conducted in the USA. And in this study, which included almost 400 patients screening prospectively with non-invasive tests from primary care and endocrinology clinics, they found a prevalence of advanced liver disease, including also newly discovered hepatocellular carcinoma, unfortunately, of about 10% of the patients, so quite high. Finally, my takeaways on therapeutics, I think there were some interesting data presented on therapeutics like on the resmetirom, FGF21, a new formulation of pioglitazone, and others. So I think the future is bright. We may also therapy in terms of pharmacotherapy. It's just that obviously the disease is so takes years, to develop, and also fibrosis years to regress. So we still need to be patient to have newly approved drugs for NASH related fibrosis. So overall, a great meeting, Mike.
You fit a lot into a couple of minutes. That's awesome. Just a couple of questions on what you said, if that's okay. The first is non-invasive testing clearly was talked about a lot at this meeting. And so a number of the specialists that spoke, including Stephen Harrison, also said that it will likely start with FIB4, as you said, because that's available and it's inexpensive, but that it will also require combination with other non-invasive tests. Do you agree that it's going to take more than one really to assess?
Excellent point, Mike. I totally agree. I think that sequential algorithms of tests which have a different actually approach to the diagnosis of fibrosis, like a biomarker and possibly an imaging or physical test like elastographic techniques. I think this is the way to go, especially in low prevalence settings. So where we want really as a first step to rule out all possible patients who are at very low risk of having advanced fibrosis, and then with the second line test, instead, we want a higher positive predictive value to identify patients with advanced fibrosis. So I think this is definitely the way to go.
Yeah, that's great. I also, one other question I had, the resmetirom study, Madrigal's piece that they did. I thought what was really interesting is that they chose to do the phase 3 arm as they called it mimicking real life, in that it didn't require a biopsy. What did you think of that? That was pretty innovative, right?
So I think it's quite innovating. As you know, regulatory organs still require histology as endpoint. But in my opinion, I think it's excellent to see that there are also randomized control trials and which try to approach the endpoint in a different way. Because as we know, it's mostly due to liver biopsy, for example, the high screening failure rate that we have currently on undergoing clinical trials for pharmacotherapy for NASH. So I think this is great. These are great data. Obviously, it will take more data. It will take more approaches like that to validate this kind of different approach. But I think it's very nice to see more innovating a different approach to the endpoints of pharmacotherapy for NASH.
Thank you, Dr. Giada Sebastiani. You're awesome as always. Thank you for joining Fatty Liver Alliance and having this chat post AASLD 22. And of course, we'll be there for 23 with you. And I look forward to lots of new innovations through the year. Thank you very, very much.
Thank you, Mike.